Hello, I'm David Kerr, Professor of Cancer Medicine at the University of Oxford. Today, I'd like to talk about a couple of the interesting abstracts, talks, posters that were presented at the recent ESMO meeting. All of us are becoming increasingly used to tapping into streamed live major cancer meetings, and I think the ESMO team have done a fantastic job of pulling together a great program and delivering it on a technical platform that I think works really well. So a big thumbs up for ESMO. Well done. As always, when one dips into these meetings, one comes up with an eclectic mixture of the things that captures one's attention. I was very pleased to see that our Japanese colleagues had represented again their randomized phase 3 trial comparing primary tumour resection plus chemotherapy versus chemotherapy alone in incurable stage 4 colorectal cancer patients. They presented updated results. They randomized 160 patients, and the patients received going straight to chemotherapy or surgery to remove the primary, followed by chemotherapy. The primary outcome of the study was overall survival, and there was no survival benefit for resection. In fact, if anything, there were 3 post-operative deaths due to complications in the resection arm, and therefore they come out with a very firm conclusion indeed, saying that resection of the primary tumour is not recommended for colorectal cancer patients with an asymptomatic primary tumour and synchronous unresectable metastasis. This is a study which I think is influential. It is small, and clearly we'd love to have seen greater numbers, but we've had a big debate in our MDT for a couple of years now. There are some observational studies which give conflicting results, suggesting indeed that there may have been benefits from having resection of the primary tumour, but in this first randomised trial, there are no benefits at all, and therefore we would not now make a recommendation as suggested by Japanese colleagues and authors. So I think an important study that's been very influential for our MDT. Quite a bit of work at the meeting looking at low copy number circulating DNA and its role in the adjuvant setting in early disease, but quite an interesting study that I picked up on from an Italian group looking at circulating tumour DNA for the resection of minimal residual disease in patients after resection of metastasis. This is an area that we need a lot of help in. We know that in 70% of patients following hepatic or pulmonary metastatectomy, the disease recurs. And there's a big question mark as to whether we should be offering adjuvant chemotherapy. In our MDT, we do not. We don't think that there's sufficient evidence of the benefits of post-metastatectomy quasi-adjuvant chemotherapy to offer it routinely. In this study, the Italian group looked at a total of 100 patients. They had a nice nested PCR methodology for detecting the circulating DNA. And the results, small study though it is, were rather compelling looking. What they found was that minimal residual disease positivity is determined by measuring the low copy number DNA was observed in about half the patients, of which 86.5% eventually relapsed. Positive status in terms of detecting minimal residual disease was also associated with an inferior overall survival with a huge hazard ratio. At the time of analysis, this is when they reported their abstract, the minimal residual disease negative arm, 98% of patients were alive compared to only around 57% in the MRD positive arm. And without any doubt, the circulating DNA status was the most significant prognostic factor, again associated with a hazard ratio between 4 and 5. We've been searching for ages looking at tissue biomarkers that might allow us to identify patients who are at high risk of relapse and therefore in whom we might want to offer post-metastatectomy chemotherapy. And to be honest, they've been rather weak, looking at tumour burden, looking at RAS status and so on, has been somewhat helpful, but not really given us a hazard ratio that would make a difference. This study, I think, looks absolutely fascinating. It needs to be replicated, it needs to be expanded, larger numbers and so on, but very, very interesting indeed, and I think an important thing for us to follow up on. New drugs things coming through. Again, I was picking up on a study from China, looking at an early phase clinical trial combining regorafenib, multi-targeted kinase inhibitor, which is approved for third-line treatment in colorectal cancer, with a drug called toripalimab. This is a PD-1 inhibitor. They were looking at patients who had microsatellite stable disease, who had progressed through 2 or more lines of therapy. And what they found was that the combination of regorafenib 80 milligrams, 3 mg per kilogram of toripalimab, induced an overall response rate of around 13-14%, with a disease control rate 35%, progression-free survival of around 3 months. So, an interesting observation. Again, there is some other work out there looking at different combinations of regorafenib with other PD-1, PD-L1 inhibitors. And I think this gives us a sort of feel for the sorts of results that we're seeing. Disease control rates, 30 to 50%, an overall response rate in the low teens, that sort of order of it. Something that may be worthwhile considering in combination. But again, always with regard to the potential toxicity of regorafenib, something that one would watch over. The final thing I picked up on is just an area that troubles us, and it's to do with the cardiotoxicity associated with fluoropyrimidine chemotherapy. This is quite a nice study from Italy. Again, relatively small numbers, only 135 patients. But interestingly, in this cohort, 20% of patients suffered a cardiac event. This could be a dysrhythmia, it could be destabilizing angina, heart attack. But I think all of us who give a lot of fluoropyrimidines are becoming increasingly anxious about the cardiac side effects. And we do need better biomarkers to understand the biology and what patients would be most sensitive. What they showed was that there seemed to be no relationship with pre-existing cardiovascular comorbidities. Now, they've done some biomarker work looking at BNP, brain natriuretic peptide. They're looking at some other markers with microRNA that haven't been sufficiently, it's a relatively small cohort, that haven't been sufficiently informative. We're doing a lot of work in our group looking at germline polymorphisms, and we think we may have identified a lead from one of our large genome-wide association studies that identifies patients at risk. It's awful when it happens. We've had a small but entirely memorable number of sudden cardiac deaths, usually in first exposure to fluoropyrimidine, and ours have been relatively young patients treated in the adjuvant setting, and one never ever forgets that, never ever. So anything we can do to better understand biology, come up with biomarkers, the better. So good ESMO. So one or two small bagatelles for you to look at and consider. I'd be really interested in your feedback on the ESMO meeting as a whole. I'd be interested in your feedback as to what you thought about attending these very large meetings virtually. Does it work for you? In fact, is it better than having to travel to Chicago or to Madrid or wheresoever? Is it here to stay, the day of the virtual meeting? But for the time being, Medscapers, as always, thanks for listening. For the time being, over and out. Thank you.